Thank you very much, Graham, and good afternoon, everyone. I'd like to say from our point of view as well, our relationship with Prostate Cancer Foundation in New Zealand is absolutely fantastic. It's great to work with you guys, especially because a lot of the medical societies across the Tasman as well, I'm talking about obviously USANZ, the Urological Society, the pathologists, and also the drug companies. So it's really fantastic for us to be working together. It really is. Now, just one thing I need to say, which is it hasn't happened so much this afternoon, but one could be forgiven for thinking there was only one rugby match played last night, but there were actually two. And we're really pleased that the New South Wales Waratahs won their match as well, so it'll be a great final. Yes, what I want to talk about this afternoon is some things that are going on in Australia, which I hope will be very relevant to the very interesting discussion that's actually gone on today. I want to talk about three things primarily. Some new resources that we're developing. Secondly, some work we're doing on PSA testing, which has obviously come up a lot today, and the controversy over PSA testing. And thirdly, just to talk very briefly about some work we've done to help patients and their families and carers to get involved in prostate cancer research. So starting with resources, John Childs mentioned that there are no current resources for advanced prostate cancer. You guys would be well aware that, of course, in Australia we're behind you guys. We're 2 hours behind, so that's given us 2 hours to prepare ourselves and show you this, our new advanced prostate. Whoops, what did I do? There we go. Our new advanced prostate cancer pack. So I'm too frightened to move the mouse, this is on our website. It's available in a physical version and it's available to download as well. There are 4 booklets in the resource which are about diagnosis, treatment, side effects and wellness, having been diagnosed with advanced prostate cancer pack. This is a piece of work, advanced prostate cancer. This is a piece of work that we've done in partnership with Cancer Australia, which is the Australian government's principal cancer control agency, we set about doing this because in Australia the advanced prostate cancer community said to us very much that they wanted to see a specific resource for men with advanced prostate cancer. So we do also have a localised prostate cancer pack for men who have recently been diagnosed with localised prostate cancer, available on our website. And I'm pleased to say that shortly we will also have a specific resource for gay men who have been diagnosed with prostate cancer. And I know that you've got a very active Rainbow Blue group for gay men here in New Zealand, which is absolutely fantastic. We also are supporting the establishment of support groups for gay men affected by prostate cancer in Australia. And the reason for that is the issues for gay men are different from the issues for heterosexual men. Essentially for 2 reasons. One is the nature of intimate relationships and practices, if you like, and the second, the social network for gay men. So it's often assumed if a man's diagnosed with prostate cancer that he's got a wife who will be the partner and carer, and so on and so forth. And of course, some men in the gay community are in relationships, but others are not in monogamous relationships, and so the issues for that community are very different. So we're very pleased to say that we'll be launching those resources on the 21st of August, and shortly afterwards we'll be launching resources for younger men, and following that for partners and carers. And I'm also pleased to say that we've talked to our friends and colleagues at Prostate Cancer Foundation of New Zealand, and we're more than willing to make these resources available to New Zealanders, and also to provide the text, if you like, of the resources so that they can easily be converted into resources which are more specifically addressed to the New Zealand community. So, moving on, I really wanted to talk about the work we're doing in PSA testing. So we've heard a lot about PSA testing today. We've heard that the test is imperfect, but we've also heard that it's the best available test that there currently is, which is certainly true. And we've heard a little bit about the controversy over PSA testing in New Zealand. The same, of course, is true in Australia. Some years ago, prominent professor at Sydney University, a guy called Simon Chapman, who's done a lot in the anti-cigarette smoking debate in Australia, co-wrote a book with a medical oncologist, Martin Stockler, called Let Sleeping Dogs Lie, which essentially advocated the idea that we've heard a little bit about today, which is you'd actually be better off not to get yourself tested, just leave the thing alone and wait and see if something happens as a man. So that's one side of the debate in Australia, and we also have some pretty vociferous people on that side of the debate, including Associate Professor Ian Haynes, who we're regularly talking to, who also advocates the same sort of thing. And then, of course, on our side of the debate, we, like you, are suggesting that men should have a conversation with their doctor. In our case, if you're a man over age 50 or 40, if you've got a family history of prostate cancer. And so the debate kind of goes on and on and on and on in Australia as it does in New Zealand. At the same time, what's interesting, just to provide some context, by the way, in Australia, PSA testing is reimbursed on the medical benefits schedule. So if you go for a PSA test as an asymptomatic man, it gets essentially paid for by the government. And so at the same time as this debate is going on, there is an enormous amount of PSA testing going on in Australia. And we heard earlier about why it might be that there's more diagnosis per 100,000 of men with prostate cancer in Australia than there is in New Zealand. And I don't know, but I would be reasonably certain the reason for that is the very, very high rates of testing, PSA testing and DRE that are going on in Australia. So we actually know through MBS records that the rates of PSA testing, even though there's no formal screening program, there's no advice to Australian men to go and get themselves tested from the government, even in that situation, the rates of PSA testing are very similar to the rates of breast screen for relevant women for breast cancer, and also rates of screening for cervical cancer for women as well. So something of the order of 25% of men in the relevant age groups in Australia are being tested every year with the PSA test or the DRE. So we know that the rates are very, very high. We also know some other perhaps less fortunate things from the data. We know that some men are being tested at very young ages, under 30, which is likely inappropriate. And also there's quite a lot of testing going on in older men in their 80s and so on. And we have heard a number of times today about the theory that if you haven't sort of been diagnosed with prostate cancer by the time you get to an age where your expectation of life is less than 10 years, then perhaps it's not appropriate to do testing, because that might lead to treatment, which might lead to side effects, and you won't actually benefit from the treatment because you'll die of something else first. So we know that there's a lot of testing going on, but we also know there's a lot of, frankly, inappropriate testing going on in Australia. And we also know, because we do something we call a community attitude survey, which we've done for 12 years now, which is a large survey of attitudes of Australian men towards prostate cancer. We know from that survey in 2012 that something like 40% of Australian men are confused about the advice about the effectiveness of the test. And I think that we've heard that in some of the questions today, which is, well, should we be doing it? Shouldn't we be doing it? I mean, we're telling people they should, but now you're saying it's not the, you know, it's not a perfect test. What does it all mean? So we certainly find all of that. And so as an organisation, the position that we took some 2 years ago was perhaps a bit of a different position than others around the world have taken, and we hope will be a circuit breaker, which is, when we thought about it, we thought, well, this controversy is not helpful. It's leading to confusion, and it's frankly not helpful of the medical profession as a whole to be kind of at war with itself, so that the general public are in a position where, if you listen to GPs in Australia who recommend against testing, or you listen to the urologists in Australia who recommend for testing, but hang on a minute, they're all members of the medical profession, they're all trained doctors, how can they have a different point of view? So we took the view that what we needed to do was help to reach consensus in the Australian medical community about PSA testing. And in saying that, we understand very clearly that when we reach consensus, and we will reach consensus, when we do that, there will be some starting positions that we had as an organisation that we may not be able to hold on to because of the evidence and the discussion and debate. And similarly, that the other side will also need to move towards the centre so that we can reach a position where we're talking to the Australian public, men and their families, about PSA testing, and everybody is saying exactly the same thing. And we think that that would be the most helpful development in Australia, and actually probably the most helpful development around the world as well, because the problem is not unique to Australia or New Zealand, as I'm sure everyone's well aware. So what we did is we went to see Cancer Council Australia. For those who don't know, Cancer Council Australia is the umbrella body for the state-based cancer councils in Australia, and those are non-government organisations, they're not-for-profit, non-government organisations which support cancer control across the whole spectrum of cancer. And prior to it being called Cancer Council Australia, the then Chief Executive, Professor Alan Coates, was actually on PCFA's board, and he took, and that organisation has consistently taken, a very anti-stance towards PSA testing well before my time, but led to a situation where Professor Coates sort of had to leave our board because he was publicly advocating against PSA testing as a board member of an organisation that was publicly advocating for it. So why did we do that? We did that because we thought, if we're going to get consensus and we're going to reach the position that we want to reach, we have to embrace both sides of the debate. We did hear actually from the previous speaker, the acknowledgement that there has been overdiagnosis and overtreatment as a result of PSA testing. And we felt as an organisation, we've got to understand that part of what the other side is saying is actually evidence-based and correct, and that we need to work together with the other organisation in the country that represents cancer control more broadly and has historically taken a different position than ourselves, as a very symbolic position to take, if you like, that we're working together on opposite sides of the debate to reach consensus. We've then gone out to involve the full spectrum of the medical professional craft groups, if you like, that have an interest in prostate cancer. So obviously we're working very closely, as we always do, with our good friends at USANZ. So Professor Mark Frydenberg, Phil Stricker, David Malouf, Frank Gardner, as urologists, are all on our committee. We like to work very closely as well with our pathologist friends, and the pathologists, of course, have historically pretty been much in the same sort of position that we're in on the pro-PSA testing side of the debate. So we're working with Paul McKenzie and Ken Sakaris on our expert advisory panel. But then we've brought in, if you like, people who have historically been on the other side of the debate. So the Royal Australian College of GPs, who have a book, the Red Book, which talks about preventative health, and they recommend against routine screening in the Red Book. The author of that advice is a guy called Professor Chris Delmar, who's a professor at Bond University, and one of his close associates, Professor Paul Glazier, who's a methodologist. They are both on our expert advisory panel and representing the Royal Australian College of GPs. We also have some very senior epidemiologists. I'll particularly mention Professor Bruce Armstrong, who's a very senior epidemiologist. He was director of the Australian Institute of Health and Welfare. He has previously been deputy director of IARC in Lyon, the international agency for research into cancer. And his colleague, Professor Diane O'Connell, who's a senior epidemiologist at Cancer Council New South Wales. And I would say also, and I won't mention them by name, but we've involved allied health professionals involved in psychosocial care, rehabilitation and so on and so forth. So we feel that we've brought together a multidisciplinary panel that covers the whole spectrum of issues that need to be dealt with prostate cancer, but also includes both sides of the debate. And it's been an interesting experience, but probably not interesting in the way that you would imagine. So you might imagine with bringing together a group like that, we would have immediate fisticuffs on the panel, if you like. And certainly at the first meeting we had, which was in October 2 years ago, Chris Delmar and Paul Glazier were sat on one side of the table, and on the other side of the table were the urologists, sort of looking at each other, and we thought, this will be interesting. But they had a very, very interesting, informed debate on both sides of the argument, on both sides of the table, if you like. And what we found, I'm pleased to say, is actually that there has been a real spirit of collaboration, a real spirit to actually reach consensus and get something done. So we're really pleased about that. Where we've found it interesting, and it's been very interesting for me listening to some of the talks today in this regard, is we sat down to develop our clinical questions for our guidelines that we're developing. And we're going to publish these guidelines next year. We're developing them under the National Health and Medical Research Council in Australia, their external guidelines development process, because that's the gold standard for development of guidelines. And we sat down and we came up with 20 clinical questions, and I'm certainly not going to go through them all, but I just want to talk about some of the things that we're looking at as part of this guideline development. So, should men in higher risk groups, for example, men who've got a family history of prostate cancer, be given different advice about when and how frequently to be tested than men in the general population or not? What age should you start being tested if you decide that you want to be tested? We heard from the previous speaker that USANS and the AUA recommend a first test at age 40. We actually recommend a first test at age 50, and others recommend different things. So what age should we start? How frequently should we be tested? Should you be tested every year, or should you be tested every 5 years? If you've got a low PSA reading at 40 when you have your first test, do you need to come back every year? Or can you wait 5 years, or can you wait 10 years? What age should you stop being tested? At what age is your likelihood of dying from something else so great that there really isn't much point in worrying too much about whether you are going to develop prostate cancer or not? Next question we're looking at. What are the criteria for referral to a urologist? So your GP does a PSA test, you come back with a reading. Do you need to go to a urologist or not? I don't know about New Zealand, but certainly anecdotally in Australia, we hear of men who have a PSA reading of 25 and their doctors, their GP saying, oh, you don't need to worry about that, that's fine. Seems a bit odd to me, I have to say, and I should probably put in the disclaimer, I'm not a medical doctor, I'm a scientist, not a medical doctor, but what is the level at which you should be referred? Should it be 4? Should it be higher if you're older? What actually should it be? We've seen a few diagrams of trust biopsies today. One of our questions is what represents an adequate biopsy? How many cores do you actually need for it to be an adequate biopsy? We know that over the years the number of cores has been going up and up and up, but is there an upper limit at which you don't need to add any more cores because it's not adding any value, or not? And finally, we've heard obviously a lot about active surveillance. What are the best decision aids to help men who are being considered for active surveillance make their own decision about whether they want to go on active surveillance or not? What should we say to them? How should we help them make that decision, best make that decision about what to do? And I guess, perhaps in a way, the most valuable experience and slightly shocking experience for us has been in this subject area. There's an awful lot of opinion, but there actually isn't an awful lot of evidence. So there are lots of people going around saying, well, you know, PSA velocity is a thing we should be looking at, or free to total PSA ratio is really a more valuable predictor of whether you've got aggressive disease than just the PSA level on its own, or some of the drug companies spruiking, some of the companies spruiking their particular variants of the test. Others saying, you know, you really need to have a first test to establish your baseline PSA level at age 40. But what we've discovered so far is a lot of these ideas, and they're good ideas, and they have great proponents for each of the ideas, but you actually need to do an awful lot of work to establish through the literature, through a systematic literature review, whether they're actually correct or just somebody's opinion, or whether they're just based on one small paper which really doesn't necessarily have the best study design to it. So from a science point of view, okay, that's an interesting result, but it's in a small group of men and it wasn't actually conducted very well. And so really, you know, we can't build our whole future management of prostate cancer off the back of that one study. So that has been probably the most important learning for us. What it's led us to do actually is realise that there is a lot more work that needs to be done. And as a result of that, we've currently spun off, if you like, 2 projects, the most important of which is to build an epidemiological model of prostate cancer, a model where we can actually change some of these parameters and see what happens. See, one of the problems when we're talking about the US study, PLCO, or the European study, ERSPC, is they started a long time ago when treatment of prostate cancer was very different than it is today. In the European study, the different countries don't actually have quite the same criteria involved, and also they have a particular approach, regimen if you like, which is, you know, we're going to give people PSA tests every 2 years, we're going to have the cut-off at 4, or whatever it happens to be. But what they don't do, and what we're never going to be able to do using that approach, is see, well, what happens if we move that interval from 2 years to 4 years? What would happen if we moved the cut-off from 4 to 6? We actually need to build a model so that we can test all those different things out. We simply can't go back and find another 190,000 European men and wait another 14 years to figure out whether it would be better to test people every 5 years than every 2 years, for example. So we do need a model that will help us to do that. And the other thing that I would say, which is interesting, is there's an awful lot of talk about the benefits of PSA testing weighed against the harms of subsequent treatment if you're discovered to have prostate cancer. And of course, you know, naturally, the proponents of PSA testing talk about the benefits and highlight those, and the detractors talk about erectile dysfunction and urinary incontinence and what the rates really are and whether they're being measured properly and all those sorts of things. But actually, I'm only aware of one paper where anybody's actually tried to quantify those two things in a scientific way and balance them against each other. So people are saying, well, you see, the problem is erectile dysfunction. That's terrible. That's a terrible harm. I mean, you know, we can't be having that just because you happen to now know that you're not going to die of prostate cancer. But how can you measure those two things against each other in just that qualitative way and know what the relative importance of the various side effects relative to knowing that you've been cured would be for a man? So one of the things our epidemiological model will do is allow us to actually, in a proper quantitative, scientific way, actually balance those things out in different testing regimens. So the work goes on. We've been doing it for 2 years. We are launching the public consultation of the guidelines at the Union for International Cancer Control meeting in Melbourne on the 4th of December this year. So everybody will have the opportunity to comment on our work, positively or negatively. And we really do hope that it will make a difference. We're certain it will make a difference. It will be a first for Australia, and it will actually be a first internationally. And we hope what it'll do is what we think is the most important thing: bring an end to this ridiculous kind of mudslinging over PSA testing and put us in a position where, as one of the previous questioners said, we can all say the same thing to men and their families and know that we're really coming from a position where we won't be attacked by somebody for what we've come to say. So that's PSA testing. Could we just move on to the next website? So finally, I just wanted to just briefly mention that we get a lot of requests at Prostate Cancer Foundation Australia from researchers to help them recruit people to be part of their studies. It's normally psychosocial studies, but it's not exclusively that. We also get asked if we can advertise clinical trials and so on, and we've tended to do that in a relatively disorganised way, in the sense that you know, we have a pretty rough and ready process for deciding whether we think the study is worthy of our support. And then what we tend to do, if we think that it is send an email out to our network and go, hey guys, does this study, would you like to take part? So a couple of weeks ago we launched this, Pathfinder Prostate Cancer Research Register, which website is www.pathfinderregister.com.au, and it's an opportunity for men and their families to register their interest in participating in research. And we welcome any New Zealand men and their families who would like to take part as well, because a lot of the trials are actually trans-Tasman trials. We heard about TROG, for example, earlier today. And the idea is that we will accelerate research by enabling our researchers to recruit much more quickly, not only for psychosocial research, but those who might be interested in participating in some of the interesting clinical trials as well. The same Martin Stockler, who I mentioned earlier as a co-author of Let Sleeping Dogs Lie, is actually now quite a good mate of ours. He was at the Australia-New Zealand Urogenital and Prostate Cancer Trials annual scientific meeting in Melbourne a couple of weeks ago, when we had, may even only been a week ago, I can't remember now, time flies by. And he was at a breakfast of our launch, and he's involved in two studies that ends up doing Enzamed and Enzarad, which are enzalutamide with radiation and pre-chemotherapy. Very good studies, and he's very keen to use this to help him find people to participate in that study as well. So with that, I'll close. Thank you very much for your time, and I hope I've been managed to show you what's going on in Australia.